Hi, my name is Jesus Gomez Manso. I'm an outreach specialist here at Reach Out. So today we're going to be going over our opioids and MAP project presentation. Um, so what the MAP project is, it's a project, well, it's known as a MAP Access Points project. And what it is, it's basically a project that's funded in order to have local organizations connect in the community and have different community partners within the Inland Empire learn about the opioid epidemic and opioid use disorder, and work to help educate the community and help destigmatize the disorder, as well as help destigmatize and educate on the medication assisted treatment, which is what we're going to be talking about throughout this presentation. So as we begin with the presentation, it's important to have a quick overview of what we're going to be talking about. So these are the 5 topics that I really want people to leave this training knowing a lot more about. So if let's say you're giving out this information, this is sort of like a guideline for some of the major points that you should hit. So we want to be able to understand what opioids are, which would then lead into understanding what opioid use disorder is, and then talking a little bit more about the opioid epidemic and why we're doing the work that we're doing. And then in terms of treatment, bringing up medication assisted treatment, which is the purpose of this whole project, is to increase awareness of the treatment itself. Um, and then once we get an understanding of what the treatment is, getting a better understanding of why people aren't necessarily using the treatment and what we can do in that front. So as we begin our presentation, we really want to set the tone of what it's going to be. So it's really important to set agreements beforehand to make sure that people understand that the space that you're creating is as safe and non-judgmental as possible. So we want to be respectful. We want to stay away from making assumptions and judgments of people. We don't necessarily know what someone is going through. So it's really important to watch what you say, um, and really be respectful in that regard as well. And it's also really important to start to use stigma-free terms. Later on in the presentation, we'll talk a little bit more about the impact of stigma on the MAT treatment and on opioid use disorder. So it's really important that we start to destigmatize both of those things in order to really help the people that need help. So as you go along giving this presentation, you want to get a base knowledge, a quick, I guess, glance at what people already know. So we want to ask them what an opioid is. So you just want to ask them to raise their hand to this question, and then you want to ask them to name an opioid if they can, who has heard of opioid use disorder, and then who has heard of medication assisted treatment. So this is a great way to understand where people are and whether you need to focus on different aspects of the presentation a little bit more in depth. So it can be a really helpful tool in crafting how you present the information to your particular audience. So before we begin, or as we begin, I should say, we want to start with opioids in general to get that blanket knowledge so everyone's on the same page as we work along in this presentation. So when it comes to opioids, we want to understand that opioids are a source of, or a set of drugs that are used primarily to reduce pain. They are commonly given to people who are suffering from cancer pains, but they are also commonly prescribed after medical procedures such as surgeries or like wisdom teeth surgeries or any sort of major surgery. and they come from two sources. So one of them comes from the natural poppy plant, and then the other one is made in laboratories. So it may be that people say opiates or opioids. They refer to the same thing. It's just um, the source of where they came from. So for example, heroin and morphine would be more of the natural substances, and then um, oxycodone and hydrocodone would be more of the synthetic. Now, as we look at opioids throughout history, um, I think it's really important because the situation that we find ourselves in currently with our opioid epidemic, um, it's not something that happened all of a sudden. It's not that a lot of people decided to just one day go out in the street and start taking opioids. Um, if we look at the history of how opioids have been in the market, especially here in the US, you can start to see some of the patterns that have pertained throughout history. So morphine was one of the biggest opioids used during the Civil War, and then once the war was over, um, there was a lot of veterans and veteran families who were actually addicted to opioids. So the government, seeing that, they decided to start work on a new drug that they said was non-addictive, and that drug was actually heroin, which was being marketed as non-addictive. It was even given to kids in their cold syrup. Um, so after introducing that into the market, then they started to notice that heroin was actually very addictive, and so there were several laws put into place to stop the distribution and the use of heroin. Unfortunately, that led to a rise in the opioid black market, and it also greatly harmed communities of color because you took away people's heroin, so they would go illegally to procure the heroin. So unfortunately, a lot of the communities that were addicted and seeking and using or heroin through the illegal black market were the communities of color. So a lot of the laws that came afterwards that criminalized heroin and caused incarcerations, deportations, and some even death penalty cases in the communities of color um, were because of heroin and the rise of the black market around heroin. And then more recently, we saw that pain was being treated as a vital sign. So to treat this, doctors would or they started to overprescribe opioids if somebody came into their clinic seeking help for pain. Their go-to seemed to be opioids because that was in their terms the best way to treat pain. So we've been seeing that overprescription, the consequences of that overprescription currently in this current epidemic. Um, and then even more recently, there was a new drug that was released into the market known as Oxycontin, which once again was marketed as a non-addictive drug by the pharmaceutical company that created it. And they did this with no no evidence, no backing. So they literally paid off doctors to make commercials and really market this drug as non-addictive without any sort of backing. So as we can see, a, this has a very cyclical nature in that there's an opioid drug, and then it gets overtaken by another opioid drug that seems to be non-addictive, or at least marketed as such, and then that cycle continues, and we have people going on opioids and then falling off of them and then going into the black market to seek cheaper alternatives, which can be um, a very dangerous cycle as we're currently seeing. So unfortunately, a lot of people who fall into this cycle of prescription drugs and then end up on illicit opioid drugs develop what is known as opioid use disorder, which is a medical condition which leads to impairment of daily life. This condition, it is chronic, and which means that there has no cure, and the only thing that someone with this disorder can really do is symptom management in order to try and get back to their normal life. And it often begins by prescription drugs, which have been prescribed by their primary care physicians. So as I mentioned earlier, they get prescribed these drugs. Oftentimes they get prescribed in bulk, and then people start taking the drugs. They get addicted to them, and then when the doctor refuses to up their supply, that's when they hit withdrawal, and then they start seeking cheaper alternatives, which end up leading them down the path to the disorder. Um, Ultimately, long use of opioids can permanently damage the brain chemistry of an individual, which is one of the biggest reasons why it is really difficult to get off of an opioid once you become addicted to it, which is something that a lot of people don't really understand, and that's why a lot of the stigmatization that's around the disorder tends to be around the fact that people believe that if you are taking opioids, it's by choice, when oftentimes it's not that you choose to, but now your brain has been altered in such a way that it's difficult not to go about your daily life without them. So currently, the opioid epidemic, what we're seeing is that about 2,400 individuals just here in California die every year of an opioid overdose death, and most of them are prescription drug related. So unfortunately, these are really staggering numbers. And then to bring it even more into focus, um, here in Riverside County alone, we have about 144 individuals in 2018 who died of an opioid overdose, and then that many visits to the ER, that many hospitalizations. And I think the most shocking one is 1.4 million prescriptions for opioids were given in this county alone in 2018. Now, when we look at 144 deaths compared to the population in Riverside County, it may not seem like a lot, but it's important to take into consideration the fact that 144 deaths or 144 people died of something that was preventable, something that we know has a proven treatment, something that should at this point in time be zero. There's 144 deaths. So as we talk a little bit more about the treatment options, it's important to understand that there's a whole chunk of the community that is suffering from this disorder and they're dying, and there's a treatment option that we can offer them which can save their life. So talking about treatment, this specific project that we're working on here at Reach Out is a project that is meant to bring awareness to medication assisted treatment, also known as MAT. And basically the gist of the treatment is that it works on 3 separate levels. So as we can see on this slide, the treatment itself is a mixture of medication, therapy, and support. Um, the integral part of this treatment is that it really takes a look at the individual on a whole level, from a holistic view, meaning that you really look at the individual instead of just the disease, which is really powerful when it comes to providing treatment for any sort of condition. So you offer the person a way in which they have a say in their own treatment plan with their doctor. So their provider basically does an initial assessment with the person, and then they come to a mutual agreement on what sort of path they're going to take with this treatment. And I'll go a little bit more into depth about what that means. But the key point on this slide is that this treatment provides that holistic approach that can be really beneficial to people. And it can really reduce the need for having people or patients be hospitalized, and it can really help sustain recovery and help them return to a normal life. So at the bottom of the slide, you can see we have three different medications, and these medications are all used for this treatment, and they each do something a little bit different, but they're all proven to be really effective. So the first treatment we have up here, or the first medication I should say, is methadone. So methadone is basically a replacement method for opioid management. Methadone is monitored dose of opioids that gets prescribed by a specialist. So it can work by preventing withdrawals, and it can help reduce risks of having the individual go out and try and get their opioids through a street supply, which can be dangerous if they don't know where to get safe opioids. And then the way it's administered is through a daily liquid dispensed only in specialty clinics. So that's one of the biggest drawbacks of methadone, is that it has to be administered at specialty clinics on a daily basis, and that sort of plan can be very hard for someone with opioid use disorder to strictly follow. So it can be a little bit difficult for them to adhere to that treatment. Next up, we have naltrexone. So naltrexone is a method of opioid management that primarily decreases cravings. So the way that naltrexone is administered is a little less restrictive than methadone. It's given in a daily pill, which would require visits to primary care physicians. But it's also administered in an injection that's on a monthly basis. So at most, they would be visiting the doctor once a month for their injection. So it's a little bit more accessible than methadone, and it primarily works on decreasing cravings. So people aren't always thinking about where they're going to get their next dose of opioids if those cravings aren't really affecting them mentally. And then finally, we have our third option, which is the most accessible out of the three, being buprenorphine, which is a way to manage your opioids and decrease negative withdrawal symptoms. So the reason I say it's the most accessible one out of the three is because it can be administered or it can be prescribed by a doctor, but it can also be prescribed by mid-level practitioners, so like a registered, not registered nurse, so like a nurse practitioner, or it can even be implanted into the arm for a 6-month period, meaning that once it's implanted, the person or the patient doesn't have to worry about upkeeping with maintenance and taking a daily pill, so they can just put it in their arm and then be good to go for those 6 months. So it works by curbing withdrawal symptoms and also the cravings. So it can really help them focus on their therapy and their support, and not have to be focusing so much on trying to get their next dose of opioids. So buprenorphine is really one that this project wants us to focus on, because it is the most accessible out of the three, and we feel that it can really bridge that gap between people with opioid use disorder and treatment options. So you may be wondering how it works, or how MAT works, or how any of these medications work to combat this disorder. Well, the biggest thing that they do is when they're taken by the patient, the medications go into the brain and then they block the receptors, um, the opioid receptors, basically, which normalizes the brain chemistry that I was talking about earlier, and it also normalizes body functions. So when somebody goes into withdrawals, they get fevers, headaches, they get sweats, they get shakes. So with these medications, their body normalizes, so they're not going through all those different changes. Their brain chemistry normalizes, so they're not fighting their cravings, they're not fighting their symptoms. So that way they can really focus on their therapy and their support. And then once therapy starts, the therapists start teaching the patients on different coping skills, different cognitive reframing options. So oftentimes when people rely on drugs to get them through life, it's because their coping skills aren't the best. So let's say they lose a job or they lose a loved one, they don't necessarily know how to cope with it, so they numb the pain through the use of medication. So with this therapy, therapists are teaching patients on proper coping skills. So if something negative like that were to happen in their life, they know how to handle it and how to deal with it without falling back onto drugs. So the programs are for an individual basis. So as I mentioned earlier, this treatment option really does take a whole person approach. So one program for one individual will be completely different from a program for another individual, depending on their needs and what their doctor and they come to, or which conclusion they come to regarding what's right for them. And then the duration of the treatment, of course, varies as well. So some people choose to stay on it for months, some for years, and some people decide to stay on it for life. Either way, as long as that conversation is being had between the patient and the doctor, they can choose to go any which route and then be an effective form of treatment. So once again, as I mentioned earlier, this particular project that we're working on really has a high emphasis on buprenorphine because it is the most accessible method that MAT offers. So specifically, how it works is that it blocks any other opioid from being absorbed into the body, and it prevents withdrawal symptoms from happening. So it is very long acting, so less doses are necessary. One dose can last a few hours to a few days, so people don't have to constantly be coming back into the clinic to receive their next dose. So these are what I believe to be the two biggest benefits of buprenorphine. As I keep mentioning, it increases the access to it. So physicians can prescribe it as well as mid-level practitioners. And then unlike methadone, buprenorphine can be prescribed through a variety of different avenues. So it can be in physicians' offices, but it can also be in like community hospitals or even correctional facilities. And then we have the ceiling effect that buprenorphine has. So what this means is that when somebody takes buprenorphine, the opioid effects of this drug, they plateau. So even if the person were to take more of buprenorphine, the effects will not keep increasing. So if someone was looking to get high off of buprenorphine, they would not be able to because the effects of the opioid plateau at one point, which is far below the usual level of opioid effect that someone with opioid use disorder has. So it would not be getting them high at all, which makes it have less chance of an overdose, and it also makes it safer in the case that somebody does overdose off this drug. And then it also decreases diversion, meaning that um, there's a less chance that it'll make its way out into the illicit market, the illegal market, because it's not giving those same opioid effects that other opioids usually do. So people aren't really going to want it because it's not giving them the high that they desire. So diversion and abuse is relatively low. So when we talk about this treatment, it sounds like it's a great option for people with opioid use disorder. So why aren't more people joining in on the treatment? It's a little bit hard to say, but there are certain barriers within our medical system or within our communities that prevent people from seeking out this treatment. Um, so now we're going to talk a little bit more about these barriers. When it comes to this particular presentation, this is a slide where if you're presenting to an audience, you want to provide this question to them so they can start thinking about what other variables other than the ones you're going to talk about are within their community and what sort of actions they can take in order to help people overcome those variables. And it's a great conversation piece to have right in the middle of this presentation. But specifically, the barriers that I'm going to talk about are stigma, specifically because this project, the MAT Access Point project, wants us to have a big focus on destigmatizing opioid use disorder and MAT in general. So when it comes to stigma around opioid use disorder, the misconceptions that I have listed on here um, are some of the more common ones, but the general theme across them is the fact that they all seem to blame the individual for their disorder. Um, so across these different misconceptions, um, they're blaming the person for having this disorder, as if to say you have this disorder because you choose to take opioids because you want to be high all the time, and that's just not the case. So when we're talking to someone with opioid use disorder, we really have to check our words. So instead of calling people addicts, we can call them a person with opioid use disorder to really look at them as a person and not just their disorder. When we're talking to someone who may be going through this disorder, we don't necessarily know all the different factors that went into them acquiring the disorder. But when we're talking to an audience, it's important to remind them that when somebody has a disorder, there's a lot of different factors that go into it. So, for example, social factors. Let's say they lost their loved one, or their relationships aren't as strong as they need to be to support them. There's biological factors. So maybe they're more biologically inclined to get addicted to certain drugs. And then there's also psychological risk factors, as I mentioned earlier. Some people just don't have appropriate coping skills to help them through tough times, so they fall back on substances. Um, so to look at an individual and say you have this disorder because you want to have this disorder, it's really harmful and can really push someone away from treatment options and from seeking these options because they feel like they're just a burden on someone, and it can be one of the biggest barriers that someone has to cross if they're ever seeking treatment. So once again, viewing an addiction as a moral deficiency and not a medical condition is very detrimental to our community and our fight to help people with this disorder. And then we have stigma, not necessarily around opioid use disorder, but more so around the MAT treatment itself and also the medical field. So these are some of the more common misconceptions around MAT, but their general theme is that they believe MAT is not a real treatment option. It's simply replacing one addictive drug for another. Um, and that's absolutely not true as well. So when somebody gets on a medication for opioid use disorder, that medication isn't providing them a high like an opioid would. So what the medications are doing is they're simply relieving the symptoms of withdrawal, the symptoms of cravings, so they can focus on their therapy. So they're not getting high off these meds. They're not choosing to buy them off the black market and go home and just get high and not do anything in terms of recovery. These are really medications that can help them focus in on their recovery. Um, so there seems to be a lot of discrimination in the medical field around this treatment. So let's imagine someone comes into the ER after having survived an overdose. Um, and then the way they get treated in the ER might be completely different than someone who comes in having suffered a heart attack. So someone with having suffered an overdose, they'll come in, they'll probably get pumped with naloxone or Narcan, um, and then they'll be sent back out into the street to fend for themselves. On the other hand, someone with a heart attack, they'll come in and they'll become high priority. They'll get checked out immediately. They'll be checked into the hospital probably overnight, just to make sure that they're okay. And then they'll be released and checked in with on a regular basis. So why is it that both of these are life-threatening um, emergencies, but one gets more better or it gets better treatment than the other one? It should be that they get equal treatment, but it's because this stigma that this person who had an overdose, they chose to have or they chose to use the drugs, so it's their choice. They're seen as lesser than someone who comes in with a heart attack. And same thing goes for the medication itself. A lot of medical providers, a lot of courts, a lot of judges, a lot of AA meetings, they see the medication as um, people still being on drugs. So let's imagine the way diabetes is treated. So someone with diabetes, they get given a medication that can help control their symptoms, keep them under control, so they can then focus on living a normal life. Well, the exact same thing is true for opioid use disorder and MAT. The MAT medication is given to someone with opioid use disorder so they can treat their symptoms and focus on getting back to a normal life. So once again, both of these are the exact same thing, but one of them is seen as normal and the other one is seen as taboo and thus gets stigmatized. Um, so we want to really focus in on trying to break that stigma, so we can really provide the appropriate help to people who need it the most and really start to push MAT as the legitimate recovery option that it is. So moving forward, these are just some suggestions on um, how you can help us through this MAT Access project, or if you want to go on and do further learning and education yourself, how you can help with this general messaging. So always be on the lookout for more information. So learn more and educate more. So the more you learn, the more you can educate the community about. Check your language. Make sure you're not stigmatizing people. You're not stigmatizing the disorder, the treatment, especially in audiences where there might be someone seeking treatment. If they see that you're stigmatizing the disorder or the treatment, then they're less likely to come to you afterwards with with their confidence and really seek out that treatment. And also just make yourself a resource to your community. Learn more about what your community has to offer for people with opioid use disorder, or learn where in your community they offer MAT treatment, and really just put those resources out there into your social spheres so people know where to go whenever they need help. And then the last one here is support your local preventative initiatives. So reach out to your local nonprofits, see if they're doing anything around this type of work. Use the medication drop boxes or for example here with Reach Out, we have some medication drop off boxes. So we have one at the Jurupa Valley Sheriff Station. So you can just go to this drop box during operating hours, and then just throw away any medication that you have that's extra that you don't want getting into the wrong hands or getting out into the community. You can go put it in the box, and then we'll dispose of it appropriately. So these are just different ways that you can help. You don't always have to put yourself out there if you're not comfortable, but there's ways that everybody could help. And then finally, we have our resources. In terms of locating treatment for people, I've put up some resources that I have found personally that show legitimate treatment centers and treatment hospitals. One of the biggest things is fraud around treatment. So make sure that if you're seeking treatment for someone or for yourself, that you're doing it through legitimate avenues. That way, there's a less likely chance that you'll run into any sort of fraud. So these are all just different resources that you can utilize. They're all really helpful, and they can help you learn a lot more about the disorder and the treatment. All right, that's the end of the presentation. I hope you learned something new, something interesting. If you have any questions, always feel free to reach out to me. Again, my name is Jesus Gomez Manso. You can go ahead and call the Reach Out office here in Jurupa Valley, or even in Upland, and they'll redirect you accordingly. But if you have any questions, just feel free to contact me.